Managing a small pupil with phacoemulsification comes with its own challenges. When we have a limited visibility because of the small pupil, it can make the nucleus management rather difficult. In this following case, I'd like to discuss with you how we achieved some amount of a pupillary dilatation and how, when you have a small pupil, sometimes the hydrodissection is difficult and then breaking down the nucleus may be difficult as well. And when faced with both these challenges, how we managed the case from there. Let's now move to watching the surgery. Now here's a patient who presented to us with a grade 2 nuclear sclerosis and a small non-dilating pupil. It's important that we pay meticulous care to attention whilst creating both the main incision as well as the paracentesis incision. An intracameral mydriatic solution is injected with the view of trying to dilate the pupil, after which we stain the anterior capsule with blue dye, after which the blue dye is washed out of the anterior chamber. Viscoelastic is then introduced into the anterior chamber to remove the residual blue dye and the air bubble. You can see that we have a fairly small non-dilating pupil. With the help of two Y-shaped hooks, a stretched pupilloplasty is next performed with a view of dilating the pupil. The stretch to the pupil is made both in the horizontal and the vertical meridian. Some more viscoelastic is introduced into the anterior chamber to achieve some amount of a viscomydriasis, after which we proceeded to performing the capsulorhexis. Now you've got to be careful to make sure that the capsulorhexis doesn't go under the pupillary edge because of lack of visibility, which may then make it difficult to navigate and complete the capsulorhexis. In this case, we've now completed the capsulorhexis. Next, we proceed with the hydrodissection, for which the viscoelastic is first removed from the anterior chamber, after which we proceed with the hydrodissection. Now, performing a complete hydrodissection itself may be challenging in a small pupil for lack of visibility of the rhexis edge. Having completed it, viscoelastic is introduced into the anterior chamber, after which I proceed with the nucleus disassembly, wherein I plan to perform the direct chop. Prior to performing the direct chop, some amount of cortex overlying the nucleus is cleared to aid the visibility of the anterior surface of the nucleus. Let's start with the direct chop. I impale into the nucleus, and having got a good hold of it, I attempt with a long chopper to chop it into two halves. Unable to do so, I try to rotate the nucleus, and as you can see, I'm having some challenges in rotating the nucleus in this case. So where do we go from here? You've got a non-rotating nucleus, a soft cataract that did not divide with direct chop. So the safest option in a scenario like this is converting from a direct chop to a stop and chop. Therefore, it's very essential that even as direct chop surgeons, we should have the skill set of sculpting a groove right down to 90% of the nucleus to be able to then mechanically divide it, having done so. So converting to the sculpt mode of phaco, I start to now create a groove in the same area where I attempted a direct chop. Notice how I work my way within the area of the pupil itself to create a short but a deep groove in the nucleus, after which, with the help of the phaco probe and the chopper itself, I'm able to mechanically divide it and create a complete fracture, thereby dividing the nucleus into two heminuclei. Under a viscoelastic cover, I now attempt to rotate the nucleus, to turn it around such that the heminucleus comes to face the area of the phaco probe to be able to then facilitate the downsizing of each heminuclei. But much as I try to do so from either side, I'm unable to rotate this nucleus significantly. How do we now proceed further? Still with the small pupil, we've got two heminuclei. How are we to engage, impale and bring the heminuclei out after downsizing it? Let's see how we proceeded with this case. I decided to try and break down the left heminucleus in its current position. Taking advantage of the mini flare tip, I just rotated the tip in the other direction towards the left impaired the nucleus and was able to break it down. Now, once you've got the first fragment out of the eye, which is what I did, having emulsified this fragment, it's easy now to achieve a rotation of the rest of the nucleus. Having then defined the size of the heminucleus, I impale into it, draw it up, further downsize it on its way up, and emulsify both the smaller fragments thus created. With half of the heminucleus thus emulsified, the other heminucleus is rotated, impaled, chopped, brought up, and the fragments emulsified. With this we complete the rather challenging nucleus disassembly and emulsification. Under viscoelastic cover, we now proceed to performing a bimanual irrigation aspiration. The non-dilating pupil does result in limited visibility even during the bimanual irrigation aspiration. One needs to be careful to not accidentally pull on the rex's edge, the pupillary margin, or the posterior capsule. We have now managed to successfully complete the bimanual irrigation aspiration. The rest of the surgery is quite routine, where under viscoelastic cover, you will wash the implantation of the single-piece monofocal IOL in the capsular bag. When faced with a small pupil, you've got to be sure that the haptics go within the capsular bag. The lack of visibility may make it a little challenging to be able to see where exactly the IOL is going. So you have to make sure that sometimes you withdraw the pupil to ensure that the entire IOL is within the capsular bag. After which, as you can see, the excess viscoelastic is removed from the anterior chamber and from behind the IOL by performing a gentle rock and roll movement of the IOL. Having completed the visco wash, we then proceed with the stromal hydration. This now brings us to the end of this surgery. Performing a phacoemulsification in a patient with a small pupil with an associated soft cataract comes with a different level of challenges. We've just experienced those challenges here, and this is the way in which I believe you could get by and complete the case safely. I do sincerely hope you found this video tutorial useful. Thank you.